Welcome to episode 3 of Hatching a Plan. My name's Simon. I'm Emma, the embryologist's husband.
I'm Emma the embryologist, and this is Simon. Is that? No?
I think that's it.
Sorry. Yeah.
I think that's how we do our intro now. Maybe we should do that every time. But thank you so much, folks, for joining us today. So just to clarify, I am the tech geek. I am not a medical professional. Emma is the expert here. And today, this is all about PGT. But before we dive into that, we thought we'd get to know the audience a little bit more. So we are based in Teddington in Greater London. So if you do want to share where you're dialing in from today, that'd be lovely. Kind of get to know where the audience is, whereabouts you're based. If you don't want to share, you don't have to, but it's always nice to hear from where folks are dialing in from today. So whilst those comments are coming in, Emma, why are we doing this podcast just before we dive into this topic today?
Well, you call it a podcast. And I don't think we've ever really spoken about that. We're turning this into a podcast.
Yeah, that's right.
Because this started off as a live webinar educational thing. And then we got talking and we were like, actually, it needs to go out in different places so that people can listen to it as well as watch it live or watch it on YouTube and all of that thing. So
yeah,
it is a podcast.
It is.
And we're doing it because I don't think it should be that difficult for people to get information about all of this stuff. I don't think you're going into a journey that is so complex and complicated, and I just don't think you should fight that hard to find out what I believe are quite basic facts.
Yeah, absolutely. And I've how long have we lived together? About 18 years now. 18?
Too long.
Too long. Oh boy. Oh, that's awkward. This is live couple. But in those 18 wonderful years, I've been listening to Emma. And Emma, if you don't know Emma already...
It says listening, drowning and draining on.
No, Emma has serious passion about what she does. Like day in, day out is there just to do amazing things for people and to help people from all walks of life to move forward with whatever treatment they're going through. So yeah, she's ace. And if you're not familiar with Emma, then please do follow her on Instagram at Emma the Embryologist. We also have, as mentioned, the podcast, which is available. If you head over to where have we got that link now? Oh, I haven't got that link to hand. We'll talk about that a little bit later. But if you look up Hatching a Plan on various podcasting platforms, it will be available. So there's 2 episodes so far. We've got Choosing a Fertility Clinic, Understanding the Vienna Consensus, and then our last episode was Everything You Need to Know About Donor Sperm. Loads of fascinating information shared on there. So we've got some people dialing in from all over the world. This is wonderful. Okay, let's go back to the top. So we've got Ascot. Hi there, Ewa or Ewa. Apologies if I mispronounced your name. Eva. Ah, okay. Lauren from Vauxhall.
Just down the road.
Ah, there you go. And Kelly Weybridge, just down the road as well. Laura from Luzerne in Switzerland. Hannah from Gloucestershire. Melissa from Costa Rica. CA. Oh, would that be California?
I don't know.
Oh, wow. Amazing. From Woking, Hertfordshire, Croydon, London. Oh, Yannicka, you're in Greece at the moment for your IVF.
Oh,
got
amazing.
it. Yeah. And Seppi from Aberdeen. And Kelly, very kind words. She is great on Insta. Yeah, she is indeed. Emma really tries her best to just, schedule with, we have a family and you are very busy at your clinic, or clinics, I should say. Yeah, both clinics. And what's your official title?
Oh, it's got lots of words in it. I am the Director of Embryology and Genetics for the Evewell Group. So I've got a clinic in Harley Street and a clinic in Hammersmith, and I divide my time between the two. And I have a very lovely, wonderful, big team of 15 embryologists and admin assistants and stuff that make it all work.
Yeah, they're awesome.
It's all about the team. It's never about the I. I'm quite nervous about this one.
How come you're nervous? What's up?
Because this is my area of expertise. So really, I want to get this right because it's something I genuinely believe people should be aware exists. I think people have gone through IVF without even knowing about PGT, and I want to try and swing it on its head about where and how you use it. So I'm quite nervous about this one because it's something that is. I'm a genetic disease expert, so I deal with genetic disease, which we'll come on to. So I'm really keen to get this right.
Yeah, I get it. So, folks, please go easy on Emma. But saying that,
You haven't gone easy on me, it's fine.
No, this is amazing, right? So Emma asked, put out like a Q&A thingy on Instagram, and we have got a whole load of questions to get through. This is amazing. So thank you so much to those that are joining us that have already asked their questions on Insta. We've got some brilliant questions come through. So we've got a copy of them we're going to whiz through. But before we do that, what is PGT? Like, let's step right back. What does it stand for? You know, why does it matter? Where does it come from? Like, give us a bit of history.
Where does the PGT come from?
Yeah. What was pre-PGT? Why did PGT?
So PGT started in probably in the mid 90s. Ali and Handyside did the first one, I think, at the Bridge Clinic in London in 96.
Right.
And it was looking for, from memory, it was trying to detect Fragile X syndrome, which is a condition that is inherited through families. And they created a group of embryos, and then they used the technology, very basic technology back then. I mean, it's not basic, but it is now, according to where we are now. And they managed to help this family have a baby that was unaffected from Fragile X. So it started in disease. It very much started in disease. Cystic fibrosis came next. Huntington's disease came probably after that. The cancer genes, the BRCAs, trying to rid families of really, really hideous genetic disease. That probably happened in the late 90s.
Yeah.
And then in the early noughties, we started developing a process called FISH, fluorescence in situ hybridization, which allowed us to see just 5 chromosomes. It was all done by staining, and that's when we used to biopsy embryos at day 3. We now know that probably wasn't our greatest idea, because embryos are only 8 cells at day 3. So by removing a cell, you are removing an eighth of its overall makeup, and we then really don't know how many of those embryos didn't grow because of that biopsy. And you're going back to like the noughties. So it's
and you got into it in 2008?
2008 I did my biopsy training. So I've been biopsy trained for 16 years. I started in day 3 embryos, and then we moved into blastocyst biopsy in 2000, and I want to say 11 or 12 when we started doing that. So that's been about 10, 15 years ago.
Amazing. Okay, so with a bit of history, let's dive into some of the questions. And thank you, folks. I can see on the comments there's some questions coming in. We will do our very best to get to them. We're going to start first with the questions that we had via Instagram, and then for folks sharing in the comments, thank you so much. We will do our best to get to them. We have got another 50 or so minutes, so we might have to go rapid fire. I think you like rapid fire.
Well, do we want to do what it is first?
Like, okay. So we've done the history.
Done the history of what it was. So what is it? Pre-GT stands for Pre-implantation Genetic Testing. And that doesn't define what we're testing for. That is the process of us removing cells from an embryo at a certain stage in its development to try and diagnose it for what we're looking for. If that's disease, that's disease. If it's what we call aneuploidies, which is when most embryos are all embryos are made up of chromosomes, and those chromosomes, half of them come from the egg and half of them come from the sperm. And as we age as women, we make more mistakes when we make our eggs, because we're born with all our eggs. I think people are probably quite familiar with this idea now. If the embryo content of chromosome copy number is incorrect, it's called an aneuploidy. So, for example, a Down syndrome embryo, I use that because everybody knows what it is an extra copy of chromosome 21. So you are 46XY, I am 46XX, and a Down syndrome embryo is 47XY or XX, but it carries that extra copy. You can have less copies or more copies, and some of them are compatible with life and some of them aren't, but ultimately the majority of these embryos will result in miscarriage, failure to implant, So the most common reason we use PGT now is what we call PGT-A, which is pre-implantation genetic testing for aneuploidies. I'm not going to keep saying pre-implantation genetic testing because it takes ages.
PGT-A.
Yeah. Got it. And then you've got something called PGT-M, which is when we're looking for a monogenic disease, and that's when we're looking for specific genetic disease. And actually the laboratory process for us doing it is identical. We are growing embryos. We are taking a few cells from a blastocyst on day 5 or day 6 or day 7, and we are then freezing the embryo, and the tiny amount of cells, between 5 and 8 cells that we take from the outer cell line of the embryo, gets sent to a genetics testing lab.
You have a specialist
The testing they do determines what they find out. My process is the same.
You tell them what to test for? Okay, you say, right, this specific type of test or groups of tests.
Yeah. I tell them what I want
Yeah.
and what the patient is after.
Yeah.
If it's a genetic disease, it takes a little bit longer to work up. We have to go through the process of gaining parental DNA to do some matching exercises. But if it's PGTA, which I would say 95% of the work I do is PGTA, then I send them the cells and I tell them that we are wanting a PGTA result for each embryo.
Got it.
Okay, so that's what PGT is.
Yeah.
The process for me is a biopsy. It's the growth of an embryo. It's an embryo getting to the right stage, and it's freezing those embryos down. Embryos are always frozen when you do pre-implantation genetic testing, because it takes between a week and 2 weeks, mainly towards the 2-week mark, to get the results. So you can't then be transferring embryos back until you've got the results, because then they would just be unscreened. So we call them screened embryos or unscreened embryos. I think that's the way it's sort of spoken about in the UK.
Yeah. Cool. So just to clarify that, you mentioned about the UK. So you're UK based. Obviously, you're connected to many clinics across the globe. But when you talk about PGT, is it specific to the UK, or could it be relevant to other parts of the
PGT
globe?
is done in the same. It's probably done by the same 6 or 7 companies all over the globe.
Gotcha.
But it's what you're allowed to know about the embryos that changes from
so
the country.
based
So
on the
in the
law.
US, you're allowed to know the gender of the embryos.
But not
In the UK, you're not, unless
no.
it's medically relevant. So there are circumstances. Fragile X is a prime example that it affects boys more than it affects girls. So you can do gender selection on embryos.
You have to know. You have to
You
know.
don't have to know, but you can choose to know gender. It's complicated, but in this country, you are not allowed to gender identify an embryo for anything other than medical reasons.
Cool. Just clarify, this country, UK, based in the UK, because your clinic's UK based.
Yeah.
Cool. Still nervous? Are you all right? Kind of easy?
Yeah, a little bit, but go.
Let's
do
go.
it.
Okay,
Fire.
let's get stuck in, folks. Okay, here we go. So, would you recommend PGT after 4 early miscarriages, 5, 6.5 weeks losses?
Yeah, I would. And I think this is one of the main players for me. Early miscarriage, the more, I think I always say this when I do any sort of talking topic. I'm going to take emotion out of this, because no one can determine how long emotionally anyone takes to get through a miscarriage. It's a very personal journey, but scientifically and clinically and medically speaking, an early miscarriage is normally anything before we've seen a heartbeat, or anything that's probably before 7 or 8 weeks. We call it early. I think it's quite derogatory to call it early.
Yeah,
A loss is a loss.
Yeah,
But
absolutely.
clinically, an early miscarriage before 8 weeks is medically quite manageable, and it doesn't normally impact on the time it takes for you to try again. Emotionally is a different conversation. If you are miscarrying that many times, the most common reason for early miscarriage, unless you've got an underlying disorder that maybe the doctors haven't checked or something, there are things that cause miscarriage, but it is mostly, we know that 80 to 90% of miscarriages are caused by genetic aneuploidies, so the wrong number of chromosomes.
Yeah.
It's actually nature's way of being kind, and I know that sounds really awful. A genetically aneuploid embryo will either not make you pregnant, because nature is actually good at quality control, or it will miscarry because the body and the embryo knows that the information isn't correct. Think of it like a blueprint, and the blueprint can't make the building grow, so the embryo doesn't keep growing, so it miscarries. However, if you do continue to miscarry like that, and then you require surgery for those miscarriages, they can also lead to long ongoing scarring problems in the uterus, which can stop you getting pregnant, full stop. So yes, I do think PGT, this is where I would use it in the younger age group, actually, because it's not really recommended in women under 35, given that what we're trying to do is, for me, it's about reduction in time to pregnancy and getting you there quicker, so that you're not wasting valuable time and financials and resources and emotional horrendousness. But in women of under 35 with recurrent miscarriage, I would use it.
Yeah.
I think it's incredibly powerful.
Okay, on to the next one. Would you recommend it being PGT for someone who has had 5 failed cycles, currently now aged 40?
Yeah, 100%, because again, like I've just said, the embryo either fails to implant. But in some women, there's definitely a difference in women. Some women will grab onto every embryo and miscarry them. Other women just won't get pregnant with them. You can decide yourselves which is kinder. I think that's a very personal thought process as well.
Yeah.
At 40, we know that only between 25 and 32% of our embryos are going to be genetically normal in a 40-year-old. Maybe you might be lucky and it could be as high as 35%, but overall we know that we're on the flip side of our early 40s. So given that if you are able to create a group of embryos, and we know, say from example, 5 embryos, only one of those is going to be normal, why don't we just work that out and only use that one embryo And then at least you know, going into a cycle with a normal embryo, that if that doesn't work, we know that we've done everything we can to make it work. I would also be having a very, very good look at, before I got to someone to put a euploid embryo back that had this many failed attempts, I'd be looking at all the other stuff as well, just to make sure it's not something else.
You often talk about like the holistic, like not just, it's not one specific thing. You got to look at history. You got to look at everything that's happened in the past. Okay. On to the next one. If no embryos are normal, are you allowed to still transfer as potential for them to correct?
Now, I'm interested that we're getting to this quite soon, actually. So, under the UK law, we are governed by UK law, which is by the HFEA Code of Practice, which I think anyone would know is not my favourite place. But they are a regulator and they do the very best they can, and they're chronically underfunded. But in the Code of Practice, we are bound by rules and regulation. And one of the rules is, the actual wording of it is, you may not transfer an abnormal embryo in the presence of a normal. So if someone has normal embryos, you are not allowed to prioritise abnormal embryos. Yeah. There is actually nothing in the Code of Practice that says you can't transfer an abnormal embryo, but you will be very, very pushed to find a clinic that will do it, and especially given the evidence that has come out in the last 18 months about using abnormal embryos. So to give everyone some context about abnormal embryos, when we talk about abnormal embryos from recent times, so the technology that we use now, we are 98 to 99% certain now that the outcome of what we call a uniform chromosome aneuploidy, so that's a whole gain or a whole loss of an embryo. So a Downs is a whole gain, and a loss is something like Turner syndrome, which is missing a sex chromosome. There's not many losses actually that will result in live birth at all, even pregnancy. We, over the last sort of so many years, there's been studies done on this, and look, all genetic testing laboratories have their own methods, but one in particular, which I work with, called Juno, have actually done what was called a blinded study. So they transferred a load of embryos into women. They had about 400 women that transferred embryos based on morphology grade alone, so grading of an embryo. They had actually done a biopsy on these embryos, and they didn't get the results until 2 years later, because they held them in freezers and they let the pregnancies play out. Okay. Right, yeah. They then found that in the one arm there was 200 normal embryos transferred, and we had about 60 to 62% live birth rate in that group, which is what you'd expect. Yep. And they then looked, and they had about 102 uniformly aneuploid embryos, and it was 100% lethal. There was no babies. Wow. There was about 12 pregnancies, but they all miscarried. Other people have repeated that study, and overall we now know that 353 embryos have been transferred as aneuploid embryos, and there is reports of 2 babies being born, one of which everyone is convinced is actually a mosaic and not an aneuploid, and the other embryo unfortunately has come from quite a significantly, how do I word this without being rude, controversial individual in the US who has already had 5 papers redacted. So again, I'm not overly convinced. But hey, do you know what? If it's 1 out of 353, for me, that is enough of a paper to show me that all we're getting here is miscarriages and heartache. Yeah. So that's where the data stands with abnormal embryos. So in the UK, you probably won't find a clinic that will do it. There are places in the US that will transfer abnormal embryos. But the literature doesn't support correction. It just doesn't show it. It shows that if you are using the best technology now that we've got now, then it does correlate to almost 100% what we call lethality. So no ongoing pregnancies once we've done the aneuploidy stuff.
God, it's fascinating, those studies. Okay, should we jump on some questions coming in from the audience? Yeah, should we do that? So let's jump back up. Okay, so I think we had, let's bring this one up on the screen from Lauren. So I'm 42, so I think I understand the benefits of doing PGT from your previous webinars, but I believe there's a high chance that I may not find an euploid in 2, 3 or more cycles. So should I not consider giving those day 3 or 5 embryos a chance untested? Thank you for your question, Lauren.
I suppose it comes back to the stats again, Lauren. And if you are, you can put those embryos back. Ultimately, if those embryos are normal, then they've got the chance for pregnancy as a normal embryo. The risk of doing an untested embryo at the age of 42 is that there is in excess of an 80% chance that the embryos are aneuploid, and it's what comes with an aneuploid conception. You know, like I said earlier, if it doesn't make you pregnant, then yes, remove emotion. Like I said, it's heartbreaking. But if it does make you pregnant and you deal with an 8-week miscarriage that then needs surgery, you're potentially 3 to 6 months down the line before you can try again. And at the age of 42, we don't have that sort of time before we can go and collect more eggs. So I get the argument, but the realistic outcome of what happens in aneuploid conceptions needs to be discussed.
Yeah. Thank you for your question, Lauren. Lauren, appreciate you being so open with us and the audience today. A question here from Yannicka. So I have transferred a PGT euploid embryo and still miscarriage. 2 of my non-tested embryos came back genetically normal with 46 chromosomes when the issue was also tested. And this might be the follow-on. What could be the reasons for miscarrying genetically normal embryos?
I mean, if you think that miscarriage is 1 in 4 pregnancies, and even higher than that, I think, because now we all test so early. I do know about everyone on here actually, but I was testing from for our kids from day 9, day 10 after I knew I could pick up a positive pregnancy test.
Yeah.
And you've got to remember back when our parents had us, those pregnancy tests didn't exist. So what we now know to be 1 in 3, 1 in 4 miscarriages, people were just thinking their period was late 20 years ago.
Yeah, I get it. Yeah.
So we now know that miscarriage is incredibly common, especially the really early ones that sometimes go as a missed period and then you just a few days late and you have a bleed. You were actually in a biochemical pregnancy situation. So we know that miscarriage is something that happens regardless of genetics. It's definitely less with PGTA embryos. I think overall we'd say in any embryo going back that's unscreened, you've got about a 24% chance of a miscarriage, unfortunately. And that gets higher with age. As you get into your early to mid 40s, it can be as high as 50% miscarriage if you get pregnant with an unscreened embryo. We know that in PGTA tested embryos there's about a 13 or 14% miscarriage rate. And that comes down to why. And so then you would really, really need to be getting into the elements of what else causes miscarriage. Immunes, which I'm not a massive believer on, but there's definitely something in the body rejecting something. Lining, implantation factors, the microbiome of the uterus. That's why we've got a lot of other tests now that we would do. So if a woman's only got 1 euploid embryo in my clinic, for example, they will do a full diagnostic cycle to check that everything's perfect as it can be on paper before you put that embryo back, because you might not get another one.
Yeah, I see.
So a bit like I don't believe that you should be using IVF as a diagnostic tool when you can do ICSI.
Yeah, exactly.
I don't believe you should be using a euploid embryo until you're absolutely sure it's going to have the opportunity to take.
Yeah.
So there are other tests that need to be done. There's things called ERAs and EMAs and ALICEs, and there's so many things out there now. And I think they've all got a place. I don't think they're for everyone. I don't think, and like anything, I don't think it's right for everyone. But I think if you are recurrently miscarrying or losing euploid normal embryos, then yeah, we need to start looking at something.
And I guess sort of taking a step back, a lot of why we're doing these webinars, and this is a podcast and all the educational stuff you share on Instagram, is just so people have questions to ask their clinics and know what questions to ask, not just kind of just sit there thinking, oh my goodness, this is really overwhelming, which clearly it is, but just having a set and series of questions. So I think over time we're slowly going to build out a set of questions, a good crib sheet per kind of area, just to help people, just to give, your belief in education is just so important. Absolutely. Thank you for that, Yannicka. We're going to jump on to this one from Kirsten. Kirsten, is there a time frame you can PGTA test in, or could you test embryos at a later date once they've been frozen?
So you can do what we do quite a lot of them now actually. They're called thaw biopsy refreezers, and what you have to do is thaw the embryos out, which if they're blastocysts, you are thawing out the embryo. You allow the embryo to recover as if you were going to transfer it. So the aim is that it recovers, it re-expands, which is what we would aim for it to do, and then we would do the biopsy and refreeze it. Now, the misconception here is that it is harmful to freeze an embryo twice. From my data, it's not. I've got the same clinical pregnancy rates from doing it twice. I think what you need to make sure of, if you are going to do a thaw biopsy refreeze on embryos, that you're working with a clinic that will get your embryos out and allow them to do a full recovery before they attempt to biopsy them. I could biopsy an embryo straight out of the freezer. It's not challenging, but is it the right thing to do? Because if that embryo is never going to recover it's not going to make a pregnancy anyway. And you are then biopsying something that was never going to come out of that first thaw anyway.
Yeah.
So much like we do when we're doing embryo transfers from a frozen embryo, we leave them for 2 to 3 hours to make sure they are fully recovered before we do the transfer. If they don't do well and a patient's got more embryos, we will then phone the patient and talk to them about thawing another embryo to make sure they've given it the best shot.
Yeah, I see.
An embryo that doesn't re-expand, which is when it gets bigger after it's been thawed, so it thaws out and it takes on fluid again, it gets bigger and starts to make itself, we freeze them down and shrink them into balls by taking the water out. The water has to go back in and then they get bigger again.
Yeah.
An embryo that doesn't do that it has got a really, really low pregnancy potential. So the question then is, why would you put it back in the freezer?
Yeah.
So we would leave our embryos, we would thaw them out in the morning, we would leave them all day, probably till 2-3 o'clock in the afternoon, sometimes even overnight if they're still not ready. And then we would do the biopsy and refreeze them. And by doing that, I've got almost identical survival rates on the flip side of the second thaw and identical clinical pregnancy rates. So I think it can be done safely, but it has to be done safely.
Yeah.
I think there's ways that you can do it wrong.
So the question to ask your clinic.
Yeah. How long are you going to leave them after you've thawed them before we do the biopsy on them? Are we going to make sure they're absolutely intact? Because you really don't, there's no point in you paying all that money to have them biopsied and put them back in the freezer if they're not going to, regardless of genetics, whether they were just not going to survive that freezing process anyway.
Yeah. That's fascinating. And that's a great question to ask. That's like the nitty-gritty detail that I think is going to help people out there. Okay, Kirsten, thank you for that. Let's jump onto this one from Laura. Would you recommend any other type of genetic testing before getting to PGT? We've been recommended PGTA testing after 5 failed transfers. My husband already has 2 children, so if there would be a genetic disorder, could we assume this is coming from me, age 37, fit and healthy? So
genetic disorder, when you use that phrase, means a genetic disease, which is at the gene level. What we're talking about when we're talking about PGTA is at the chromosome level. So your genes are carried on chromosomes. So let's do a quick science lesson because I think this will help. So
here it comes.
On my Insta, there's a thing called the library analogy, and I think it helps just having a visual. So in each of your cells is your library. Your library is what makes up all your information, or what makes you you. It's your blueprint. Half of your library came from your mum and half of your library came from your dad to make a unique, brand new library, which is you, right? In your library, you have 23 bookshelves on the right and 23 bookshelves on the left. They represent your chromosomes. On the chromosomes, there are a load of books, different amount of books depending on the number that the bookshelf is. Bookshelf number 1, which is chromosome 1, has something ridiculous like 6,000 books on it because it's a big beast.
It's an important
It's
one.
a really important one.
Yeah.
You go down the library, and as you go through the library, the bookshelves get smaller because the chromosomes get smaller and they have less books on them. In this library, in your library, you have identical books on each side. So you have books, Jane Austen there, and you have Jane Austen here. They're identical copies. When we talk about genetic disease, what we're looking for is a problem in a page on a bookshelf.
Wow.
Because it's when it doesn't tell the story right. So there's an error, or there's a page missing, or there's some letters missing.
Yeah.
And that book doesn't read right anymore. So the book doesn't tell the story properly, so it can't function properly. Now, in some genetic disease cases, you need both books to be wrong to cause the disease. That's called a recessive disorder, so cystic fibrosis. And in some books, they're so important that even if one of the books on the bookshelves doesn't tell the story correctly, you end up with a genetic disease such as Huntington's, which is what we call dominant disease. So when we talk about PGTM, we're talking about the letters in the books on the bookshelves.
Yeah.
We're looking, and that's why we have to know where we're looking, because we can't just look at all 23,000 books in your library. When we're talking about PGTA, we're talking about the bookshelves. There are the correct number of bookshelves there. And if you've obviously got an extra bookshelf, you've also got all the extra books that comes on that bookshelves. So the embryo has either too much information or too little. With me?
100%.
Right.
That's great.
So what you're asking is a genetic disorder can actually come from either of you. But we know that because women are destined just to take the rough side of life, let's face it.
Yeah.
As we age, we're trying to make, when we create gametes, so eggs and sperm, we're actually creating a whole new library. You're halving your library to give to your egg, and your partner is halving his library to give it to his sperm. And what we know is that in females, that halving process doesn't go very well, and the bookshelves don't go in the right way. So you end up with too many bookshelves in the egg, or too little. So there is no real, right, so you would definitely be looking at testing if you were having recurrent miscarriage. There are certain genetic tests that we look at for that. But failed transfers, I think that could be genetics, but you're only 37. So I think I would be wanting my clinic to be looking at a lot more. I would want them to be looking at the environment. And like I said earlier, the Emma, the Alice's, the DNA frags in the man. Have we actually looked at him properly? Because although your embryo can be genetically normal, if the sperm isn't functioning properly, it may stop the embryo growing at a later stage. And I'm not going to go into DNA frag tonight because that's a whole other webinar.
Yeah.
But it's bigger than that. So I would be looking at everything else, but I do think that with failed transfers at the age of 37, the fact that you've had 5 failed transfer tells me that you've made at least 5 embryos. So let's test them if you do another cycle.
Yeah.
And let's find out if they're normal first, because I imagine if, and it's also about, I'm going to come on to this in a minute about family building, so you can carry on asking me questions.
Okay,
I'll just keep talking.
I'm gonna keep going. Thank you, Laura, for sharing your question. And I thought
the next one's perfect because it then keeps
this
me going.
one here?
Yeah, no, this one.
Yeah.
The PGTSR.
Wrong one. Let's bring this up from Seppi. Can you explain a bit about PGT-SR?
So PGT-SR is Pre-implantation Genetic Testing. Said it again. For structural rearrangements. So what happens here is in certain individuals, the bookshelves are all present and the books are all there, but they're in the wrong place.
Oh, okay.
So bookshelf 1 might be stuck onto bookshelf 8. And it's called a translocation. So you are normal, you are healthy, there is nothing wrong with you at all. But when you try and make gametes, eggs and sperm, the bookshelves are all in the wrong places, so you make more errors.
I see.
And you make quite specific errors. So you would make... So there's different types of translocations. They're normally called reciprocal or Robertsonians.
Can you give me an example?
So a really, really common example of a Robertsonian translocation affects people between chromosome 13 and chromosome 21. I mean, a bit of chromosome 13 is stuck on the top of chromosome 21 or vice versa. And the reason that one's really important is because when you actually make eggs and sperm, when you carry this translocation, you're basically making embryos with partial extra copies of 21. So you're actually making partial Downs embryos, and they are incredibly compatible with pregnancy and life.
Yeah.
They aren't as severely affected as Downs individuals, but they are affected. So that's the one I see a lot of. How they come about, they're normally in families. They're a bit like genetic disorders. They are a genetic disorder, but they are... So in essence, you should, if the maths was to play out, you should make 1 in 4 of your eggs or sperm should be unaffected by the imbalance. 2 in 4 will be affected and unbalanced, so have the wrong amount, either side, less or too much. And 1 in 4 will be like you, have it but balanced, so that you can make healthy embryos that way.
Yeah.
So when we do genetic testing for PGT-SR, the finale, is I actually don't know yet. That's the testing can't do that yet. It can't tell me whether the embryo is balanced or unaffected. It just tells me that everything's got the right copy number. And that's really frustrating for patients who don't want to pass this on.
Yeah.
I think it's coming. I think that technology is coming, and I think it will be with us in the next 12 months, that we will be able to tell the difference between an embryo that has a translocation like yourself and is normal, or doesn't have it at all.
Fascinating.
Because we'd rather get rid of it
if
we can, because then any children born with the same as their parents is going to have the same fertility problems in 30 years' time. So it causes lots of miscarriages. So anyone with a structural rearrangement generally has quite a lot of miscarriages because of the unbalance.
Thank you for asking that question, Seppi. That was good timing. We got into the nitty-gritty science then, so this is good stuff. So hopefully you're still with us, folks. My brain is like going, whew, right, there's that.
Mad.
So I'm,
this is why I need to get this right, because it's really complicated. Science.
Take your time, right? And if we have to go over the hour, so be it. If folks do want to stick around, we might break the rules and go. We'll see how it goes, right? We'll see how it goes. Okay, so Mel would like to know a little bit about the process and timeline for PGT-M.
This is a great question. So PGT-M is the look when we're looking for a monogenic disorder. Now this is incredibly sad, because normally this comes because either you have a family member that has been diagnosed with a genetic disease, like an elder relative, and then you start so breast cancer is a really, really obvious example for this. So someone in your family will have breast cancer. They will then get tested for the BRCA gene. say for example it's your mum, you then have a 50% chance of also having that gene. And it's so different to 30 years ago. We've now got massively good prophylactic treatment, which means you can have your breasts removed and you can have your ovaries done. Like there is things we can do to prevent the cancer, but ultimately you're still in a position where you're passing that gene on to future generations. So that is an error in a book on bookshelf number 17. That's where the BRCA gene lives. Okay. Now I think the misconception about monogenic disorders is that the page that's missing in the book causes the problem. What it doesn't, because the BRCA gene is a tumor suppressing gene. And when there is an error, it stops the gene working. So it can't suppress tumors anymore. So the error isn't causing the problem. The error switches the gene off.
I see.
Okay.
Yeah.
So BRCA is an example of a dominant disease. And if you were working up a BRCA case, I would need blood from the person who carries it. So let's say it's the woman. I then need blood from the partner.
So where are we at this point?
So they've just walked into your clinic and they've come to you for diagnosis of embryos for PGTM.
Okay, so we're on day one of...
They would come and they would meet me, we'd do an inquiry, we'd go through the whole
Yeah.
process. I would look for genetic reports. You have to have a genetic report to say what the mutation is. We would then, I would do a full consultation on these and then make sure I've got all the background I need. Now, the more family members you can get, and I talk about this as direct relatives, not cousins, it has to be a direct relative, either actually offspring is really good, daughters, sons, embryos, they're all, because they're the puzzle, right? They are you and your partner together is your reference. But you would take DNA, so blood from mum, DNA, blood from dad, and then you would send that to the genetics lab with all the information. If you have got a mum with it, you would then see if we can get DNA from her. If you've got any embryos, we can use them. And basically you're creating a puzzle so that when we do create embryos and we try and overlay the embryo's DNA, it's where do they fit? Have they got it? Have they not got it? Are they carriers? And all of those things.
And that sort of thing about timeline, how long would that all take? It
So
sounds like, is that
about 4
months,
to 6
is it?
weeks.
Okay.
So 4 to 6 weeks. What I will say about genetic disease is you absolutely have to have genetic counselling. That is mandated in the code of practice. And actually what I will say about genetic disease, some people choose not to test. When no one's mandating you test, you can't force someone to test. We will have to have like MDTs about it.
MDT?
Like a management discussion, full profile of senior people in the team, clinical team.
Yeah.
To make sure that we're happy to proceed and that we feel the patient's been informed. But we have to make sure we've covered, like got all the documentation to support treatment without testing.
Yeah.
But so the timeline from probably walking into a clinic to being able to start IVF cycle is probably, I would gear yourself up for 2 to 3 months.
Right.
Because of all the counselling and all the bits. But the actual PGTM bit, once I've sent everything to the genetics lab, they come back to me about 6 weeks later and say, we're good to go, we're ready.
And, importance about, you've touched on, you've been very scientific and very much this is what happens, this is what happens. And you've briefly mentioned the emotional side of things. So, because that's important, right?
Yeah.
The mental well-being of anyone who's going through this experience. What does the genetic counselling offer?
So genetic counsellors are amazing because they will talk you through the risk of inheritance patterns, what the risk of the disease is, if it's something that's in your family like BRCA. That has massive implications to you and your health and your future. And some people don't want to know.
They don't want to know, yeah.
And that's okay.
Totally
That's like no one gets to have a say on that. That's your journey. But the genetic counsellors will help you work out that bit. And they will help
it's so
you work.
personal.
Yeah.
Like wanting to know that information.
Yeah. So some people don't want to know.
Yeah.
And there is something called blinded PGTM, so we can do it without finding out. But that is an incredibly complicated thing to bring up and I could draw it for you, but I can't talk about it.
Yeah.
But there are options. So PGTM, I would always say if you've just found out that there's something in your family, make sure you've got much information as you can. The genetic reports are key. We have to know where we're looking. And also one BRCA patient is completely different to another BRCA patient because actually the problem in the book is different every time, most times. Does that make sense?
Yeah. It's so complex. I think the way you're describing this, and this is what I find fascinating, is how your patients across the globe in various other clinics, how they can wrap their head around some of the science and how much they need to know about the science and how much you need to kind of handhold them and say, look, as much as it can be hard not to have all the information, there's an element of trust and an element of like, we are going to work with you, present you information to help you make decisions. Is that really what it comes down to?
Yeah, and I think actually it depends on how much you want to know. I mean, I always ask patients when I'm doing these calls, because I do a full hour consultation with PGT patients, because that's, like I said, that's what my expertise is. I always ask them how much they want me to go into it.
Yeah.
Because that's quite personal as well.
Yeah,
If they want me to just take it off them, I will.
Yeah.
But you have to have counselling. It's a legal requirement.
Yeah.
And I can't do it because I'm not a genetic counsellor.
Of course, yeah.
I could do it, but I'm not clinically evaluated and licensed to do it.
Yeah. I mean, you're just, because I know what you're like as a person, like you do counselling anyway as part of the service that you offer, but not like officially, because it goes down the official route. So, okay, thank you, Mel, for that. Let's take this one from Kath. If you have never had a positive test, so never miscarried, and under 35 years of age, I've heard that testing is not recommended, but what if fertilization is happening and they are just failing to implant due to abnormalities? Thank you, Kath.
It's true. So under 35, so let's talk about what recommendation means, because my idea of recommendation and the HFEA's idea of recommendation are two very different things. The HFEA stance on PGTA is that by doing testing, you will not give anyone more healthy babies in a cycle of treatment. 100% agree. I can't change the embryos. Your embryos are what you have created.
Yeah.
And I can't make them genetically normal. So if you create 8 and there is 2, I'm not going to make more by testing them.
It's about information.
It's about information.
Okay.
So the reason the HFEA don't recommend it for under 35 is it hasn't been shown to be of a benefit when getting to a live birth. Now, what and who gets to define what a benefit is? So I touched on it earlier, and I always talk about family, not baby. So you walk in your clinic at 35 and you turn around to me or a member of the team and say, I had always dreamed about having 2 or 3 children. I now feel like that's not going to happen and I'm desperate and I just want to have a baby. I'm going to turn around and say, well, hold on a minute. You can still talk about that dream. And I know you want to be pregnant now. But if we start creating embryos now, and at 35 you have about a 50 to 60% chance of each embryo being genetically normal, and for example, say you create 4 and I come back to you and I say 2 of them are normal, you are still only 35 that month later. Now I can put one of those embryos back and make, hopefully with 60% certainty, give you a baby, but you will walk back in potentially into the clinic at 37 and your chance of now making a normal embryo is 40%. So shouldn't we have had that conversation where we pause, maybe create some more embryos at 35 so that you've got your future family planned out? So for me, that is a benefit. Equally, you are 40 years old, you're sat in the clinic and you're lucky enough that you've made 6 blastocysts and only 2 of them are normal as well. And actually it's the not the nicest 2. It's not the ones we choose in order, because we would choose them normally from grade. Yeah. So you go through 4, go through transfer number 1, and it's not pregnant, and we move on. You're 40. You then go through transfer number 2, and it miscarries. You lose 3 months, 6 months.
Yeah.
You then go through transfer number 3, and it's another miscarriage, which takes you back emotionally really hard. It hits you really hard. So by transfer number 4, you're actually a bit broken. And I've actually seen people walk away from treatment because it's called infertility fatigue, as I think we've all lived through.
Yeah.
So you might get to the point where you're now 41. You've got these 2 embryos that are normal. Each frozen transfer is costing the best part of £2,500. And you're 10, like there's a point here where people give up.
Yeah.
So you may never use them. Okay, then flip the argument around and all 6 were abnormal. To use all 6 embryos, by the time you sit back in front of a consultant having used them all, you're 41 and a half. And now I've got really, really difficult time to find an embryo. So isn't that beneficial?
Yeah.
So the argument I have for women at 35 is like I say this so much, but context is everything. No, I will not create any more babies by doing testing, but I might give you the opportunity to create your family.
Yeah.
So I think we need to think really realistically about what we determine as a benefit. because their argument is it's not beneficial. My argument is that's not your right to say what everyone's context is. It is beneficial for certain people to know what they've got before they move on into pregnancy, which takes 9 months to have a pregnancy. And unfortunately, we still get older. Our ovaries still get older even if we're pregnant, and then we might feed, or we might, you know, have a newborn, and then before you even know it, your baby's a year old, and you're thinking, oh,
Yeah.
anyway.
Yeah, no. So, I mean, I got asked lots of questions about that, but I am conscious we've got a heck of a lot of more questions to get through. So thank you for that one, Kath. We're going to jump back to some of the questions that we had via Instagram. So let's go for, here we go. Oh, this is an interesting one. Testing R2 embryos couldn't occur due to lab error at the amplification stage. Is that uncommon?
Oh, we're combining two topics here. So what did I talk about in the Vienna consensus? KPIs.
Oh, yeah.
So one of the KPIs that we have to adhere to is what we call our no result rate. Now, no results will happen. They should happen less than 5% of the time. Now, a no result is when you do the biopsy, you send the cells, and the lab send you the results, and they can't detect a result for that embryo. That embryo is just as likely to be normal as it is abnormal. Depending on your age group, it doesn't mean there's anything wrong. Sometimes poorer quality embryos are harder to get viable cells from, but we would normally warn patients about that. So my no result rate personally in the EveWell clinic group is under, I think it's 1.6%, because again, this is down to the fact that I'm really, really anal about when embryos are tested and how we test them, and we leave them to grow quite a long time, and we have lots of cells, and hey, that's what I do, right? It's the biopsy. So, but again, that's a KPI. So you will see a varying level of no results clinic to clinic, and it's something we should ask. What is your no result rate?
It's a great question.
It does happen, but actually you can thaw those embryos out and biopsy them like we were talking about earlier. You can go back to them. Now, most genomics labs that I've ever worked with will not charge you for a retest. So you get charged for the initial, but if a lab like Juno, who I work with, if they give me a no result, then I can go back to them for free and do it again.
Yeah.
Without charge to the patient.
Ah, interesting. Oh, I didn't know that was the case. I feel like we really are building a crib sheet of questions that you can go in when it comes to PGT. These are, the top 10 questions you should be asking your clinic when it comes to
the top 150.
Well, the top 150, yeah, exactly. I mean, it's not just 10, right? There'd be 15 parts to it. So where do you want to go? Do you want to take some questions?
There's a couple in here that are really similar, and I wanted to touch on them. So that one at the bottom is one of them.
Okay, let's go for that one then. So, Lisa, thoughts on lack of NHS funding for PGTA for people with a history of recurrent miscarriage?
Or advanced maternal age.
Or advanced maternal age.
Again, yeah, I agree with you. I think it's a really, really tragic, sad state that we're in, but the NHS is underfunded, and these are expensive processes. I find it incredibly frustrating that people even have to fight to have miscarriage bloods done. I mean, I've had women sit in front of me with 5 miscarriages and no one's actually done any bloods on them or anything, and it's like,
it's tough.
But yes, I agree with you. Now, I think there's another question in here that talks about PGTM. Now, while we touched on PGTM, I probably forgot to mention that when you do a PGTM test with a private external genomics company, the technology actually allows you to see both. So you not only find out whether the embryo is affected or unaffected or a carrier, depending on what disease you're looking for, you also find out the PGTA status. So you would end up with like a double result for a PGTM embryo.
Right.
So it would come back as, so let's for argument's sake do the BRCA gene again, just because it's dominant and it's 50% of your embryos. So the BRCA gene would be like it affected or unaffected in the first column, and on my second column it would say normal or abnormal for chromosomes.
Right.
So you get both elements. So you're not only just transferring an unaffected embryo, you know that it's chromosomally healthy as well. And one of the questions we had was, why don't the NHS, the big NHS player that does all the PGTM funding, not perform PGTA alongside its PGTM? So what this particular clinic is actually doing is giving you an unaffected embryo that you're then going on to miscarry because of the chromosomes. And the answer is, I don't know. It's something that has frustrated me for many, many years. I'm sure it's to do with funding, and they actually do their own in-house testing, whereas I send mine off to a diagnostic lab.
It feels like such a missed opportunity though, because you're like... Who could we lobby, or who could we...
I need to get on the HFEA board, which is something I've been putting off for years.
Yeah. So, folks, if you want to advocate for Emma to get on the HFEA
I
board,
should do. It's
you
a lot of
absolutely
work.
should do
And
this. Yeah.
Anyway.
It is more work, but it's important work. But yes,
Come on, we've got 9 minutes of a quick fire round, I reckon.
Quick fire. Okay, here we go. What morphological grading means if chromosomally normal?
So we still use the grading. So when I talk about grading, as you all know, I bang on about this enough. So actually, when you get a chromosomally normal embryo, if you're lucky enough to have more than one, and we've got a selection, then we go back to the grading, the day, the development,
right.
and we still priority
Yeah,
score them.
yeah,
So a day 6 normal embryo will still not make you pregnant as much as a day 5, because although it's chromosomally normal, it's to do with the development process and the speed of the embryo that also correlates to pregnancy rates. So we would always get better pregnancy rates from day 5 euploid embryos than day 6 and then day 7.
Yep.
Okay, that's not what drives that. That is just standard. You find that more embryos are abnormal as the embryo takes longer to grow. So 90%, or if I think it's 88% of day 7 embryos are aneuploid because they've taken so long to get there. It's because the machinery is not right. But we still use the grade and the day, even when we know the genetic status, because it helps us have a ranking score. Yeah.
Okay, let's jump on into the next one. What insight do you get from testing when all embryos are abnormal? Can it help the next cycle?
Yes, if the abnormality is a pattern, then that might have picked up something we talked about earlier, which is called the translocation. PGT SR is then needed. So you can certainly, I have in the last couple of years picked up 3 patients with unknown translocations because I saw the pattern in their embryos.
Oh, wow.
From what they were all identical patterns. So it's unusual. So normally you get random stuff with PGTA. I don't normally see, like you do see a lot of plus 21s because it's compatible with embryo development. We know that Down's embryos implant reasonably well. You see a lot of plus 18s, a lot of plus 15s. They're just really compatible things. It doesn't mean that the other ones don't happen. They're the ones where the embryos don't grow. I don't see a lot of like trisomy 2, so 3 copies of chromosome 2, because that's your bookshelf with about 5,000 books on it. So it's not compatible with embryo development. Oh, wow. So we don't tend to see them as much as we see some of the other ones, like if that makes sense. And chromosome 21 is quite small. It's only got about I think 600 books on it. It's not a big gene, which would then make sense. So you can get some insight. Equally, there was a really nice paper that came out a couple of years ago, and it said that the impact of one cycle of all abnormal embryos does not change your potential for the second. However, if you have 2 full cycles of over, and I think the number was 8, don't quote me on this because I can't remember, of all abnormal embryos in 2 cycles, it can be very predictive that this is going to be an ongoing problem. But your 1 cycle of all abnormal embryos does not correlate to your second.
Fascinating.
You normally get the same percentages in the second cycle of normality based on your age.
Yeah. I got it. Okay, some of the nitty gritty. Question on Insta: why is it so expensive with setup fees and a cost per embryo?
So I think this is really different, and I find this really interesting because I know for a fact that we get charged a per embryo fee, which the patients pay per embryo. Some clinics do a package fee of up to 8 or 9. I don't know is the answer, because I'm pretty sure all the genetics lab charge a per embryo fee. Now PGTM is expensive because it's bespoke and it has to be worked up for you. So that is and it takes the 6 weeks, and it is unfortunately incredibly challenging. So PGTM is a very expensive process. I think 1 round of treatment with PGTM, so looking for genetic disease, with all the workup fees and all the costs and the counselling and everything, can be upwards of £12,000.
Yeah,
it is tough. But I think most clinics should be charging a per embryo fee because that is how we are billed by the labs.
Yeah, I see. Good stuff there. So now we do have some more coming through on the chat. Should we jump back on the comments?
Sure.
Let's do it.
I'm pretty sure that's my sister.
Oh, yeah. Yeah, I just spotted someone in the crowd called Kelly Phillips. Might be another Kelly Phillips. But yeah, this is a really good analogy. Thank you. Yeah, nice one, Kelly. Thanks for joining us. Oh, Laura, thank you so much. Yeah, for saying thank you so much. Or thank you so much for saying thank you. This is so helpful. That's very kind. Okay, Danny, a question here. Should we bring this one up? Yeah. So I'm 37. I have had 2 failed natural transfers from 2 previous cycles. My 3rd round has led to 3 frozen euploids and just at the start of the meds for an FET. What is the thawing survival rate? Does it differ if they're euploid or not?
No. So there was a theory a while back that aneuploid embryos genuinely didn't survive the thawing process as well. And I think there's something in that, because I think aneuploid embryos tend to be poorer quality sometimes. Sometimes, not all the time. So they won't survive because of the quality, not because I don't think of the aneuploidy. Euploid embryos that have been vitrified, again, this is a KPI, right? So this is one of those things that you'd have to ask your clinic, their survival rates. Mine is 98% of our vitrified embryos at the blastocyst stage survive and get transferred. So they do very well. Vitrified embryos, which is what all clinics are doing now. I don't know any clinics that are doing slow freezing anymore. They should survive really well.
Okay, thank you for that question, Danny. We've got time for a few more, so let's go for it. Oh, this one.
I thought.
Let's jump here and then we'll jump back to Jessica. Sorry, that did flash up on screen there. So this one from Emma. Can you explain more about mosaic embryos, please?
So mosaic embryos are those that are determined on the testing to be mosaic, and they are, how do you word it? It's like there's a bit of good and there's a bit of bad, and we can't be sure of which. Is it inherently bad? So has it come from the eggs and sperm? And if that is the case, the embryo is actually aneuploid. And the mosaic result is potentially a wrong call, but it's very unusual. Or it can, if you can imagine an embryo goes single cell, right? 1 to 2, 2 to 4, 4 to 8, 8 to 16. Then let's just, for argument's sake, say one of those 16 cells makes a mistake.
Yeah, I see.
That is called a mitotic error. And why, let's just for argument's sake say you pick up some of those cells, right? But the other 15 are fine. Yeah. So the embryo itself as a whole has come from a good egg and a good sperm. Yeah. But an error has been made. So we believe most mosaic embryos, that's why they've got really good potential, is it's just a mitotic error that's happened during the process of embryo development. We know that embryos are very, very mosaic. That's just what they are. And we know that that is the only place that the good cells will then tell the bad cells to die. It's called apoptosis. So that is a mosaic embryo. It's when we've got a bit of good and a bit of bad. However, saying all of that, thankfully, we're in such a good place now with mosaic embryos that we can not only do some genetics labs now offer an extra layer of testing to see if it's good in or good out, if that makes sense. And we're getting really good pregnancy rates with them. So again, genetic counselling is key. Yeah. Because I wouldn't personally be comfortable transferring a mosaic 21 because of the impact of having a mosaic Downs individual. Yeah. But most of them we are now, I think they have transferred 2,000 mosaic embryos with about a 36% live birth rate, which is good. Yeah. And the mosaicism doesn't seem to be following through to the babies. There have been a couple affected, but no more than the normal if you were conceiving naturally.
Got it. So. Okay, thank you, Emma. Right, we're going to jump onto this one from Jessica. So would frozen embryos that were fertilised with sperm with a DNA Frag score of 54% still be worthwhile to subject to PGT testing? Or does the Frag score act as enough of a red flag already? I'm 32, husband is 41. So
the DNA Frag, like I said, I need to do something on this because it's really interesting. I might try and get Jonathan Ramsey to do something like this with me because he's really good at all the DNA Frag in the men.
Jonathan Ramsey?
He's a urologist, okay. So he does a lot on DNA Frag in the men, and I'm an embryologist, so it would make sense to bring on an expert in that one. Maybe that's series 2, because obviously we're going to have a series 2. The Frag is a red flag, but it normally stops embryos developing rather than causing aneuploidies. It's not the same. It's aneuploidies. Whole chromosome gains and losses genuinely come from the egg. I hate it. I hate that as women we're always this. You are young. You are 32, so there is every possibility that your embryos are going to be genetically normal, but the Frag itself can cause the embryos to miscarry. That needs looking into. A 54% DNA Frag needs looking into. A urologist should be checking your partner out. That's the right people to go and see for that. See if we can change it. Get it down.
Great. Hope that helps, Jessica.
I will do something on Frag because it's a massive topic, but I could be here all night talking about DNA Frag.
Yeah. I think
I could be right all night talking about anything. Really. Space this me.
Exactly. Okay, just doing a quick time check, folks. It looks like, is there one you want to take there, Em? I think we've got time just for one more, and just before we do that, apologies if we weren't able to get to your question this evening. Those that have come through on Instagram, and also those that have come through via the chat today. I think, you'll try your best to reply to some of the Q&A.
I might just put some of them back on the gram and then answer them one by one, because a lot of them I think we've covered.
Yeah.
Damage rate. Let's talk about damage. So
Yeah.
again, this is a KPI. All of these things coming back to our first podcast.
Yeah, so
it's a
that was
KPI,
the
Vienna
Vienna
consensus.
yeah.
So we have to talk about damage rates. I have touch wood. I've not damaged an embryo yet doing biopsy because of the way we leave them to grow so much. They are. I think people think about them as being really fragile. If you think about what they've actually got to do to make people pregnant and how any of us are here, they're actually really, really robust. They really don't mind what we do to them too much. It comes from training and skill and technique and all of those things. And in the right setting, embryos do not get damaged through biopsy if it is done properly. And that is all I'm going to say on the subject, because I believe that there is a way to do it and a way not to do it. And I do quite a lot of biopsy workshops, and I have done them all over Europe because it's about making sure people are doing it safely. But embryos also are not fragile. By the blastocyst stage, they are incredibly robust. I will say that. So we also know that biopsying an embryo doesn't change its outcome, because there was a paper on that as well. So embryos that had been biopsied and not biopsied, same pregnancy rates.
So studies been on it, and
that's been done. We're happy with that. Yep.
Let's pull one in, because I think this is a really good question that has come in from Lauren. Thank you, Lauren, for asking this. What sort of questions should we be asking a chosen clinic before we allow them to biopsy one precious embryo?
Those questions. So you've got a 4 or 5 layer approach there. When do they biopsy them? How big are they? Are they letting them get to the point where they're really advanced embryos, so that you're fundamentally only biopsying viable embryos? Blastocysts can be early blastocysts and still fail. That's why I leave them to be 4s and 5s, which is the grading system we will talk about. What's their no result rate?
Yeah.
What's their freezing survival rates? Because ultimately these embryos have to be frozen. So the most important KPI to your outcome is, are they going to come out the freezer okay? Yeah, I mean, I do biopsy a lot of single embryos, I must admit. And they go as well as doing a group of embryos. But those would be my questions, is mainly around the freezing.
Yeah. Yeah.
So
great. Wow. There we go, folks. I think we're going to have to stop there.
Goodness me, this topic's huge.
It is a huge topic, and it realizes we could probably go a bit more niche on a few.
Yeah.
What we will say is, do come back to this. As someone who's hosting this, my mind is melting with all the information that Emma has shared, and I mean that in a positive way. We do hope that it has been helpful for you today. Do come back to it. So follow Emma on Instagram at Emma the Embryologist, where she'll link you to all of the places. You can find Emma the Embryologist now on YouTube. So we've got 2 previous podcasts, and this one will be available as well, coming soon in about a week or so. We are also syndicating to all the podcast platforms, so Spotify, Apple Podcasts. If you want to go and find all the links to the podcast, it's hatchingaplan.transistor.fm. So do go check that out. You can come back to this. Please do share it with other folks who are out there who you feel would need some support. Do spread the word. Emma really is, I mean, as you can tell, an absolute expert and super passionate about what she does. She really is here to help. So yeah, keep on checking in, and we'll go from there.
I will get some of these put on actually, because some of them, I mean, I think we've covered most of them. I'm just looking through them, so I hope it's been really helpful. And then just feel free to DM me if I haven't answered a question that you wanted me to. I can probably put it into 18 paragraphs.
Yeah, that's it. Well, it is a skill in of itself, I think, to take something so scientific and turn it into something that's helpful.
It's hard to get your head around this.
Yeah,
it's really hard.
Yeah, I think we can do more, and maybe the practical crib sheet stuff we could start focusing on.
Yeah, definitely.
But
any suggestions, throw them our way.
Absolutely.
Because we need a whole load of content for series 2.
We do. So just some lovely messages coming in. Yeah, thank you, Lauren, for that. And very kind Hector, Kelly, Hannah, Danny. Oh, wow. Some very, very kind messages coming in. So thanks so much for sticking with us, folks. And from Emma here, thank you so much for sharing all your knowledge. We've chosen Evewell, West London, and we'll be starting our journey there soon. Thank you.
Oh, that's nice. I'll see you there.
Wonderful, Emma. Thanks for sharing, folks. I really do appreciate all the questions and everything that you've asked today. Please do come back to this and do check out the the other episodes of Hatching a Plan. I'm Simon, signing off.
And I'm Emma, off to bed before work tomorrow.
Yeah, indeed. Take care, folks, and we will speak with you soon. Bye for now.